Bismillah ar-Rahman ar-Rahim. Key points and formulas in critical care medicine. Alexandria ICU Park. Pulmonary hemodynamics and pulmonary edema. The pulmonary hemodynamics. The pulmonary circulation can be divided into two segments. The first one, which is the precapillary. This includes the pulmonary arteries. And the second segment is the post-capillary segment, which includes the pulmonary veins and the left ventricle. The peak pulmonary pressure equals the pressure here in the precapillary segment plus the pressure in the post-capillary segment. Or in another way, this peak pulmonary pressure equals the pressure resistance plus the pressure elastance. The precapillary pressure here is called the pressure resistance, and this pressure resistance equals the cardiac output multiplied by the pulmonary artery resistance. But the post-capillary pressure, which is the pulmonary wedge pressure, or we call it pulmonary occlusive pressure, or hydrostatic pressure, and this is the pressure elastance. And this pressure elastance equals the pulmonary veins stressful volume over the left ventricular compliance. Precapillary pressure, which is the pressure resistance, as we have mentioned before, it equals the cardiac output multiplied by pulmonary artery resistance. So an increase in this pressure resistance may be due to increase in either cardiac output or pulmonary artery resistance. Increase in the cardiac output as in ASCD or VSCD, but increase in the pulmonary vascular resistance may be due to showers of pulmonary embolization, hypoxic vasoconstriction, or high PEEP. But decrease in this pressure resistance here may be due to either decrease in cardiac output or the decrease in the pulmonary artery resistance. So decrease in the pulmonary resistance as vasodilating drugs or reversal of hypoxic vasoconstriction. But decrease in the cardiac output may be due to the decrease in the venous return or decrease in cardiac output as in right-sided ventricular ischemia or infarction. The post-capillary pressure, what we call the pulmonary wedge pressure, or pulmonary pressure, or hydrostatic pressure, this pressure is the pressure elastance. And we said that pressure elastance equals the pulmonary vein stressful volume over the left ventricular compliance. This pressure elastance, what we call post-capillary pressure, pulmonary wedge pressure, pulmonary occlusive pressure, or left ventricular end-diastolic pressure. And we mentioned that it equals the pulmonary vein stressful volume over the left ventricular compliance. The normal pulmonary capillary wedge pressure is between 4 and 12 mm mercury. The oncotic pressure is about 25 mm mercury. This pulmonary wedge pressure is useful in differentiating cardiogenic pulmonary edema, which is due to increase in the pressure elastance, and in this case the pulmonary pressure will be more than 80 mm mercury. From the non-cardiogenic pulmonary edema, which is due to increase in the capillary permeability, and in this case the pulmonary pressure will be less than 18 mm mercury. Cardiogenic pulmonary edema, this will be due to increase in the pressure elastance, which is pulmonary pressure or hydrostatic pressure, and this may be due to increase in the pulmonary stressful volume or decrease in the left ventricular compliance, or the two together. Increase in the pulmonary vein cesspool volume is due to either increase in the volume itself or decrease in the pulmonary vein capacity by vasoconstriction. Increase in the pulmonary volume itself may be due to volume overload as in liberal IV fluids, or venous distress due to decrease in the diastolic time as in tachycardia, supraventricular tachycardia, or rapid atrial fibrillation. Pulmonary vein thrombosis leading to unilateral pulmonary edema. Rapid AF in case of mitral stenosis, acute mitral valve prolapse, or mitral valve thrombosis. But decrease in the pulmonary vein capacity by vasoconstriction as in case of high altitude pulmonary edema, tachycardic pulmonary edema, and maybe a neurogenic pulmonary edema. The second cause for cardiogenic pulmonary edema I've mentioned before is a decrease in the left ventricular compliance. And this may be due to ischemia, infarction, hypertrophy, diastolic dysfunction, or increase in the cardiac force pressure as in high beep, pneumothorax, cardiac tamponade, cardiomyopathy, toxin, endocrine problems, or metabolic causes. Thank you.